This is going to be a very brief video lecture on schizoaffective disorder. Schizoaffective disorder is kind of on that spectrum of schizophrenia type disorder. And because, number one, there are so many commonalities with regular schizophrenia, if there is such a thing, and it is such a diversely presenting type of disorder, one that is very hard to diagnose accurately. I have given you full notes. There's no regular type of outline like I usually do, although I do have the disorder symptoms in a bulleted format, and I dress it pretty much the same way as the full outlines that I have in the past. However, because so much of it is a bit redundant to schizophrenia, I want to only go through the most important points in terms of the differences. So let's take a look at those notes that you will have available to you. And get me up here a little bit. Schizophrenia is truly a spectrum of a sort. We kind of talked about that in the regular schizophrenia lecture, that there is positive and negative symptoms, and some forms are mostly positive, some are mostly negative, but then there is a spectrum where there may be some of each. So when we're looking at schizoaffective disorder, there's a couple of things that should immediately come to mind for you. And the one is it's going to have symptoms of schizophrenia. But now we see affective, meaning mood. So we have both schizophrenia-like symptoms and also mood disorder-like symptoms. And again, I'm not going to go through and say each of these things. I'm pretty sure you're going to be able to read them. They're short. They're basically very factual. So you can take a look at these symptoms that I've listed here. You'll see very much like in the schizophrenia disorder lecture. Now, specific symptoms as we move down include the same thing in terms of the delusions, false beliefs, disorganization, unusual thoughts and perceptions, hallucinations. But now look at some of these: manic mood or unexpected boosts of energy with behaviors that are out of character. Erratic and uncontrollable temper, irritability, incoherent speech, often switching between topics that do not relate to the current conversation. And look at difficulties in holding attention. We talked about that with schizophrenia. Catatonic behavior, we talked about that. Lack of concern for personal hygiene or physical appearance. Sleep disturbances and difficulties, very often what we see with some of the mood disorders. So you can see the overlap in schizophrenia type symptoms, mood disorder type symptoms. Now, causes, again, they really don't know contributions of all the potential causes, but as we saw in schizophrenia, considered to be strongly indicative of a genetic component. According to the NIH, a person may be at an increased risk of developing schizoaffective disorder if a first-degree relative, such as a parent, a sibling, or a child, actually has it. And a person's risk may also increase if a first-degree relative has schizophrenia, bipolar disorder, or another mental health condition. This should not be surprising by this point as we go through these different mental disorders. And there's some indications. I like to put these little suggestions as to potential causes down, even sometimes if they've not been demonstrated in and the way in which we can assume that it is a for sure thing. But I think it's interesting to consider some of these things, and then we can always watch the literature as it emerges. In my introduction to this particular disorder, I mentioned the difficulty in diagnosing. And it is very difficult, in part because of this mixed bag of symptomology. And so a medical professional will base their diagnosis on that person's self-reported experiences, as well as what they observe in terms of unusual behavior that by them, the medical professional, but also what do family members, what do friends, what do colleagues of that individual report. And there can be the clinical, let's run down the DSM-5 criteria, check boxes, and a number of criteria define this condition. And part of it is what symptoms have been demonstrated, but also how long have these particular symptoms been apparent. I've listed here some of the criteria according to the DSM-5, and the criteria, this should come as no surprise whatsoever, schizophrenia with mood symptoms. Oh, bingo. This is, again, if I ruled the world thing, I love the way schizoaffective disorder. That makes perfect sense. It says what it is. Schizophrenia with mood symptoms, or a mood disorder with symptoms of schizophrenia, or both a mood disorder and schizophrenia. And again, this is one reason why it's hard to diagnose. But the name of the disorder kind of says it. And according to the APA, the other criteria include recognizing the positive symptoms. And again, those positive symptoms that we talked about in schizophrenia. And it's interesting because in 4, from the material I drew from, it says a medical professional may also note negative symptoms. Well, if they're there, negative symptoms are there, they should be noted. And these are the loss of function or a withdrawal that would probably be noticeable in a person who doesn't have the condition. So are they there? And again, these particular negative symptoms may include things that look like schizophrenia, just maybe not as extreme. For example, declining interest in previously enjoyable activities, problems concentrating, changes in sleep cycle, low motivation to leave the house, social difficulties in communicating with people. Interesting though, we need to make sure that we rule out other general medical conditions that produce similar symptoms. And this should always be number 1. It's why really, really good lab workups should be accomplished. First, before we even go any further, let's take a look at blood work and other forms of lab work that may indicate some other condition that could account for these symptoms. Such things include HIV-related illnesses, temporal lobe epilepsy. I did not want this to actually still be in a different color, and it is. Excuse me, well, I may as well fix this now. And there, I feel better now. Neurosyphilis, alcohol or drug use disorders. I'm just scooting through these. These are all important. But metabolic syndrome, you're like, what? Yes, even very serious cases of metabolic syndrome. Very important to pay attention to. And so these different diseases that I have listed, A through G, each can produce symptoms that could be interpreted as schizoaffective disorder. So let's make sure the patient does not have any of these, okay? You're a good doctor, we're gonna do this. And now we can rule these out with blood tests and scans, and we're also going to use EEG and CT scans. Why? Temporal lobe epilepsy, we need an EEG, right? CT scans can be used for some of the thyroid, some of the Cushing syndrome, even various neurosyphilis, some other things. So bizarre delusions or hallucinations consisting of at least two voices talking to each other, or just one voice participating in a running commentary of the individual's actions, meet the criteria for diagnosis alone. This is actually pretty important, don't you think? And so let me actually bring that out a little bit more. I can start doing this. That's kind of important. So make sure that you're aware of this being pretty much one thing that if it occurs, we're gonna go, whoa, we have this situation here. So there are subtypes of schizoaffective disorder, just as there are in different disorders, including schizophrenia. And there are two subtypes that include bipolar type, where a person experiences manic or mixed episodes, and the depressive type. Only major depressive episodes occur without the manic or mixed episodes. Distinguishing between schizoaffective disorder, schizophrenia, and mood disorder is, again, as I mentioned before, a diagnostic challenge. One thing though, if we see the mood symptoms are more pronounced and generally last much longer than in schizophrenia, we are looking at schizoaffective disorder as opposed to the more pure forms of schizophrenia, if there is such a thing. Schizoaffective disorder may also occur along catatonia, and in that movement, behaviors will change, and that can be observed as you go on, and as the patient moves through various stages, if you will, of the disorder. All right, now you may already have figured treatment is going to be a challenge. Diagnosis is a challenge. Treatment's a challenge with both schizophrenia and mood disorders. So now we have got this real challenging situation in one individual. So usually it involves a combination of medications such as antipsychotics, antidepressants, and mood stabilizers. And then when possible, psychological interventions such as counseling. And remember that we have to get the individual to a point where they are receptive and able to engage in the counseling, whether it's cognitive behavioral therapy or other forms. We have to make sure that patient is in a place where they can respond to such therapy. Sometimes it means being on a certain drug protocol for a period of time before that can happen. Again, difficulty in the diagnosis means difficulty in treatment. And here are some other treatments that more specifically, aside from just generally saying antipsychotics, antidepressants, mood stabilizers, here are some of the ones that can be used. Under the antipsychotics or neuroleptics, hopefully you will remember neuroleptics and what they do long after you finish this course, okay? Because it's important. And as we see neuroleptic type drugs used more and more for other types of disorders, it's important to understand what they're doing and potential side effects. So please, hopefully that's something you can hang on to. Clozapine, you've heard about that before. Risperidone, a new one, olanzapine. Mood stabilizers, which include lithium, we've talked about that before, and Depakote, we've talked about that before. Antidepressants, which include, you know, many of the ones that we would see in the treatment of depression. And that would include things like Celexa or Prozac. So you can see where many of these disorders share treatment commonalities. And when you're getting to something like schizophrenia and then schizoaffective, it only makes sense that you're going to need to implement some of the treatments that you do for schizophrenia, but also have to pay more attention to the affective aspects of this particular disorder. Again, complex, difficult to diagnose, difficult to treat. Understanding the putative causes, difficult. So hopefully at least this little tidbit of a lecture will help your awareness in terms of this challenging disorder, help you see some of the differences between schizoaffective disorder and schizophrenia and or mood disorders. And we look ahead to times where it may be more readily diagnosable, and we may have a better idea of what drugs and drug combinations may be most effective. So that's it for this particular disorder, and I will see you again very soon. And if I can ever get this